Hi everyone, so welcome to the Disability Health Committee. We're here to talk about the intersection between COVID and disability and all the nuances there. My name is Liam Doherty. I'm on the Mayor's Commission on Disability, and also I'm the Access and Functional Needs Coordinator at the at PDPH in public health. And so the video will be recorded and posted, so more participants will be able to see our presentation post-hoc. Amy, would you like to introduce yourself?
Thank you, Liam. My name is Amy Nieves. I use she and her pronouns. Visual description of myself is I'm a fair-skinned female with short grayish hair, blue glasses, and a blue top. And I am currently the Executive Director of the Mayor's Office for People with Disabilities and oversee the Mayor's Commission for People with Disabilities. It's a pleasure to have you all here with us today.
And I apologize too. My pronouns are he, him. And a visual description, I'm a white male, 30-something, with shorter brown hair. And I think without further ado, I'll let Dr. Menon from COVID containment introduce himself.
Hi, firstly, thank you for inviting me to speak to you today. I'm a physician. I'm board certified in family medicine as well as occupational medicine. I've been working with the Department of Public Health COVID Containment Division for a bit over a year, helping to fight the pandemic. In my prior life as an occupational medicine physician, I had a fair amount of interaction with folks for workplace accommodations due to disabilities. So I have a little bit of experience with some of the things that you guys may be going through. Can I share my screen now, Liam?
Sure, that'd be great. Thank you, Dr. Menon.
Okay, hopefully this will work. When I try to share my screen, it says host disabled participant screen sharing. Are you able to enable me to share my screen?
Liam, if you make him a co-host, you should be able to circumvent that.
I apologize. My technical understanding is so-so. Okay, great. Is everybody able to see my screen?
Yes.
Okay, great. Here we go. So there's a lot of information that I want to share with you today. I think it's really important to discuss some of the background of where we are, where we're at, so that you can understand where we're likely to go from here and those challenges that you're likely to face. I'll summarize the current situation and discuss some of the disability-related questions that Liam had provided, and then open it up for questions at the end. So again, some of this may be refresher or things that you know, but please bear with me. So COVID-19 is a respiratory virus caused by a virus called SARS-CoV-2. When we say it's a respiratory virus, what we mean by that is that it's spread by droplets that come out of your nose and your mouth when you talk and sing and scream or yell and cough and sneeze. The illness that people get with COVID can range in severity from absolutely no symptoms, which we call asymptomatic disease, to mild symptoms, and then symptoms that are serious enough to put you in the hospital and actually cause death. There's a number of characteristics of this SARS-CoV-2 virus, or the illness, which we refer to as COVID-19, that have made it such a difficult virus for us to get under control. And some of these unique characteristics are that about 30 to 40% of the people that get infected with the SARS-CoV-2 virus will have an asymptomatic infection, meaning that they get no symptoms and they feel well, but they're still able to spread disease to others. For those that develop symptomatic disease, which is the other 60 to 70% of the people that get infected, they're most able to transmit virus to others just before their symptoms develop. So based on those two characteristics, what we found is that greater than 50% of the person-to-person spread occurs either from asymptomatic people or people who will eventually develop symptoms, but before they develop the symptoms in their pre-symptomatic infection. And so bottom line here is there's lots of folks walking around that could have COVID and don't know it. And so those folks may be less inclined to engage in different mitigation measures, such as mask wearing and social distancing. And this is the rationale for having broader mandates regarding social distancing and mask wearing, because we just don't know all of those that are able to spread the disease to others. As I said earlier, this is a respiratory virus. It is predominantly spread in the air through large respiratory droplets. And let me explain that a little bit. So when we talk and scream and sing and sneeze and cough, there's a range of particles in terms of the size of the particles that come out of our nose and mouth. The larger particles have if you have COVID, have more virus attached to them. And the larger particles have a tendency to fall to the ground in short distances due to gravity. And this is where we get that 6 feet rule, is if you're less than 6 feet from somebody who's contagious, you have a much higher risk of getting infected because you could breathe in their respiratory droplets, and those droplets that are close to the individual are larger and carry more virus. Now, it doesn't mean that if you're greater than 6 feet from somebody that your risk of getting COVID, if they're contagious, is 0, because some of these smaller droplets will remain suspended in the air and travel in the air currents in the room or outside where you might be engaging in activity. And so in particular, if you're in an indoor environment that has poor ventilation, even if you're greater than 6 feet from somebody, there is a risk of getting COVID, but it is much less than if you're closer to folks. And again, indoor environments, much riskier than outdoor environments. And those indoor environments that have poor ventilation are much more risky than indoor environments with good ventilation. And the more people you put inside, the greater your risk. It's all statistics and numbers there. Some of the other challenges with COVID is that, prior to January 2020, this virus didn't exist, or at least it didn't exist in the US in any appreciable amounts. So none of us had any natural immunity to this virus. Add to that, that the symptoms that get caused by COVID can range from very mild to no symptoms to very severe symptoms. And those symptoms mimic other common medical problems, such as allergies. Somebody with a mild case of COVID looks as though they're just having an allergy attack. Those that have slightly more severe symptoms look like they have the common cold, and those with even more severe symptoms might look like they have influenza. And so really the only way to tell if somebody with these symptoms has COVID is to do a test. You cannot determine with certainty based on symptoms if the person has COVID or some other illness. One of the other aspects that's been a real problem is that the risk of having severe disease with COVID and ultimately getting hospitalized or dying is very closely associated with age. There was some CDC data that was published over the past few months on the CDC website that said if you were 85 years of age and older, compared to somebody 20 to 30 years of age, and the 85-year-old got COVID, you had over a 500 times risk of dying from COVID. And so COVID is much, much more severe as you increase in age. And it's also much more severe if you're younger, but you have chronic medical conditions. And so for folks with disabilities, you've got to really be careful because your disability may put you at greater risk of getting severe disease. One of the other things that's really challenged me is all of this information. You know, we have learned an incredible amount about COVID in this past year, but with the internet and social media out there, it has made it relatively easy for folks to spread misinformation and disinformation. And it's really hard to sift through the volume of information and then determine what is based on science and what is not. And I think that's been a real problem, both for us in the medical field and probably more so for people that aren't in the medical field. Add to that new variants like the Delta variant. Variants get created when people get infected with COVID and the COVID virus multiplies in our bodies. When it goes through that multiplication, sometimes there's errors in the multiplication process, and that will create changes in the genetic code of the virus and could ultimately lead to a variant. Most of the changes that we see in the virus when it reproduces in humans are inconsequential. They don't matter. But occasionally you get one that's a problem. The Delta variant is one such variant that has been a huge problem. Currently, it's the most common variant that is sequenced from people in the US who are currently infected. We'll talk a little bit more about Delta shortly. So how do you slow the spread of COVID? These are things that you guys have heard before, and it really hasn't changed. Wearing a mask, it really works. It's not perfect, and really there's no perfect one mitigation measure, and this is why we encourage people to follow multiple mitigation measures, because by doing so, we will have the most protection. But wearing a mask will prevent you from expelling these respiratory droplets, and it also protects a wearer of a mask from inhaling those respiratory droplets. The masks that we're currently wearing actually are better at preventing somebody that's contagious from expelling the virus than it is from somebody else breathing it in. But again, we now have very good data to show that mask wearing really helps decrease the spread of COVID. Social distancing also works, and we talked about why with both of these mitigation measures. You want to wash your hands often. Now, what we have found, though, is that most of the transmission of COVID is through the air. But in theory, you could get COVID from touching a surface that was recently contaminated with respiratory secretions, if there's enough respiratory secretions on the surface, and then you touch your nose, eyes, or mouth prior to the virus dying. And again, we've not seen a whole lot of transmission from surfaces, but it is still advisable to frequently wash your hands and clean surfaces. Again, the main way this spreads is through the air. You want to avoid crowded indoor places with poor air movement in particular. If you get symptoms that are suggestive of COVID, you want to get tested because, again, we don't know who's got COVID or one of these other very common illnesses. You want to stay home. Don't go to work. Don't go out in society if you have these symptoms until you get a negative test. And then really the most effective way to mitigate the spread of COVID and mitigate one from getting hospitalized or severe disease is vaccination. So a little update, what's going on right now? Well, as I said earlier, the Delta variant, there's multiple ways that we designate this variant, and that list of letter and numbers is one of the scientific ways that we designate the Delta variant. Nevertheless, the Delta variant has been for some time and currently continues to be the primary source of new infections in the United States. We had been seeing case rates dropping really nicely up until a couple of weeks ago. We were in a fourth wave of COVID, And again, the number of cases were dropping. And shortly after that, we saw the death rates dropping. And that's all because of how COVID works. People get infected and they don't get real sick for a couple of weeks, and then they end up in the hospital. And if they're going to have a bad outcome, that's a number of weeks later. So what you generally see is a delay in the death rates following the case rates, whether they're going up or down. Nevertheless, we have been seeing decreasing case rates, but since about October 26th, we've actually been seeing a flattening of this decrease in case rates. The death rates are still decreasing, but that may stop in the next few weeks. We don't know if we're going to get a fifth wave. Looking at Europe, there's a number of countries in Western Europe that are seeing increased case rates right now. We're not entirely sure why, but one of the things we do know is that as we get into the cold weather months, we're going to be inside more, and that's a bigger risk for the spread of COVID. And so I would encourage people to be cautious as we get into the winter, both because of what that means for our behaviors, as well as these case rates seeming to level off. We're still seeing the highest transmission rates, hospitalization, and deaths in those areas of the country that have higher unvaccinated rates. And we're likely to see that in further duration. The demographics of those that are getting infected has changed to younger and healthier people. And we believe that reason is because the older folks and the frail individuals have been getting vaccinated. And the vaccines do work at both preventing illness, but they're even better at preventing hospitalization, severe disease, and death. Recent studies have been showing that the vaccines are holding up against the current common variant, which is Delta, but we're also starting to see more breakthrough cases in people that are fully vaccinated. A breakthrough case is a case in somebody that has been fully vaccinated and is 2 weeks since they received their last dose of vaccine. And we think this is likely to be due to the increased transmissibility of the Delta virus, as well as vaccine immunity starting to wear off at this point in time, especially for those that were first in line to get the vaccine who were the most vulnerable. And then also the natural infection that people had gotten early in the pandemic is also wearing off. And again, all of that's contributing to more breakthrough cases in particular. There's been a lot of news about booster doses and third doses. Basically, if you were immunized with an mRNA vaccine, that's the Pfizer or Moderna, and you have moderate or severe immunosuppression, you should get a third dose of the vaccine 28 days after your second mRNA dose. We're recommending that because we have found that individuals with moderate and severe immunodeficiencies did not respond as vigorously to the first 2 shots. We now also have recommendations for boosters. If you had an mRNA vaccine, it's recommended for certain groups to get a booster 6 months after your primary series of vaccinations. It's highly recommended for those over the age of 65, as well as those that reside in long-term care facilities or other kind of chronic facilities like a prison. We recommend it for individuals 50 years and over who have chronic medical conditions. And then it is also available for individuals 18 years of age and older who have chronic medical conditions who work in areas that are at high risk for being exposed to COVID. The J&J vaccine, which is slightly different than the mRNA vaccines, that's what's called a viral vector vaccine. It's a 1-dose vaccine. Some people are arguing that it really should be a 2-dose vaccine, but that has not changed as yet. It is recommended that anybody that had a J&J vaccine get a booster 2 months after the first shot. The primary series of vaccines for mRNA vaccines should be done with the same brand, but boosters for either the mRNA or the J&J vaccines can be from any of the 3 vaccines that are currently available in the US. Just last week, the FDA approved the Pfizer vaccine for individuals 5 to 11 years of age. A few months earlier, that vaccine was approved for individuals 12 to 16. In the original approval, the Pfizer vaccine was approved for individuals 16 and older. and the Moderna and J&J vaccines were approved for individuals 18 years of age and older. There's also been some news recently about new therapeutics on the horizon. Both Merck and Pfizer have developed a pill that, if taken, significantly decreases the risk of hospitalization and severe disease. Their studies have yet to be peer reviewed by experts in these kinds of studies, but their information has been given to the FDA, and I would expect that we will see responses in the upcoming months. And then finally, there's been new regulations in Philadelphia. There's been new recommendations by the CDC, as well as new federal recommendations that are being fought, and we'll go over those now. So actually, before we get to that, what's the situation number-wise in the US and in Philadelphia? Currently, we're seeing about 68,000 cases in the US every day. And again, that number has leveled off since the past like 2-3 weeks. Realize that that's only people that are tested. That's not everybody that's getting infected. We believe that 30 to 40% of the people are asymptomatic. Those folks are very unlikely to get tested. Some people, experts have believed that the true number of cases is about 2 to 5 times the number that we measure. That's a big range, but again, not everybody gets tested. We're seeing over 1,000 deaths a day still in the US. And again, that appears to be slowly leveling off, catching up with the case rates in terms of the shape of the curve. To date in the US, we've administered over 425 million doses of COVID vaccines. So that's all 3 of those vaccines added together. So for those folks that are worried about getting vaccinated from the perspective that we don't have data, I think you probably had a decent argument right after these vaccines were authorized by the FDA and the CDC. But now we have lots and lots of data for most individuals. There's not as much data right now for the kids that were just approved, but for the rest of us, we've got a lot of data to support the fact that the vaccine is very safe. It's not without any risk, but it is very safe. It's far safer than rolling the dice and getting COVID, and it's very effective. But we are seeing that the effectiveness of the vaccine does wear off over time, which we predicted early on, and now we're seeing it happen. Over 58% of the total population in the US is fully immunized, and over 80% of adults are immunized, or excuse me, have had at least 1 dose. In Philadelphia, we're seeing similar case rate and death rate trends as we're seeing in the overall US. The city is a little bit ahead with regard to vaccinations, and so I'm very pleased to say that. I think the public health department's doing a great job with getting vaccinations out there and providing education for folks. And then, we're seeing more and more private and public vaccine mandates. A little bit more about the Delta variant. The big problem with the Delta variant is it's about 1,000 times more transmissible. And what I mean by that is easier to spread from person to person than the original strain of COVID that was out last January, which we call the ancestral strain. Some folks have estimated that the Delta variant is as contagious as chickenpox. And so those of you that are a little older than me know that if one person in a household got chickenpox, everybody was getting it. And again, COVID is similar. It is very transmissible. If people in your household have it, there's a greater chance you're going to get it than not. We are seeing more breakthrough cases in fully vaccinated individuals. And we think that that's both a combination of the characteristics of the Delta variant as well as immunity starting to wear off, especially for those that were vaccinated first after the vaccines were authorized. We've learned that individuals that have breakthrough cases can spread COVID to others. There is some suggestion that the Delta variant will cause more severe disease in individuals that are not vaccinated, but the data is still kind of limited there and we're not 100% sure. Regardless of all that, the vaccines are still very effective at preventing severe disease, hospitalization, and death in those that were vaccinated, as well as compared to individuals who had natural infection. There's been a lot of data that's come out comparing people who had COVID naturally to folks that were immunized to try to determine who is at risk for another infection after vaccination or after natural infection. And there's been some contradictory studies. The weight of the evidence right now in the most recent studies are saying that if you are vaccinated for COVID compared to somebody that had COVID naturally, that the person that had COVID naturally has a 5 times risk of being hospitalized for COVID with a reinfection. With that said, again, we're not 100% certain of that data. We're still trying to figure it out, and it's kind of hard to get good data just because of the characteristics of the virus and how we do these kind of studies. There are new variants that are coming out. The way to stop new variants is to stop infection. And again, the best way to do that is with vaccination. There's a new subvariant of the Delta variant that we're seeing, in particular in the United Kingdom. It seems to be spreading more than the prior Delta variant, but it's too early to really tell. We have found the variant infrequently in the US. To the best of my knowledge, we have not seen it in Philadelphia yet. And whether or not we will really depends on whether or not that Delta Plus variant is more transmissible than the prior Delta variant. And right now, we just don't know. Recent data on vaccines, and this is data that was compiled from early April to early September, shows that if you're unvaccinated, you have a little more than a 6 times risk of testing positive for COVID. That if you're unvaccinated compared to a vaccinated person, you have an approximately 10 times greater risk of being hospitalized and an approximately 11 times risk of dying from COVID. So again, the vaccines on average provide better immunity than not getting vaccinated. And even if you have a natural infection, it looks like the vaccines on average are better, provide better immunity. So there's been a bunch of recommendations that have come out over the past few months. In July, the CDC recommended changes for folks that are fully vaccinated with regard to mask wearing. Prior to that date, if you were fully vaccinated, there was a host of things, including indoor activities, that the CDC thought that you didn't need to wear a mask because your vaccine was producing adequate immunity. Well, what we've seen with the Delta variant is that's not quite the case. And so the CDC recommends in areas where there's substantial or high transmission that everybody, regardless of vaccination status, wear a mask when indoors in public settings. This substantial and high transmission measurements are CDC measurements, and on the website it tells you what case rates and what positivity rates equal a substantial or high transmission zone. The CDC recommended universal indoor masking for all teachers, staff, students, and visitors to K through 12 schools, again, regardless of vaccination status. You guys may have seen in the news today that the Pennsylvania court system invalidated a requirement by Governor Wolf for all K through 12 schools to mask. And so it looks like it's going to be up to the individual school districts at this time. In addition, the CDC recommended in July that a fully vaccinated asymptomatic person that is a close contact to somebody that's contagious should mask in indoor settings for 14 days after the close contact, even if you were in a lower transmission zone than substantial or high transmission, that you get tested for COVID 5 to 7 days after the exposure. And then if you're negative, you may stop masking when indoors, but that area should also be below a substantial transmission level. City of Philadelphia, lots of new requirements have come out over the past few months. The city issued a mask mandate that went into effect the 12th of August, which required all businesses and institutions that did not mandate vaccinations for all employees and patrons, that they would need to require that everybody mask when indoors in their businesses or institutions. Similarly, with restaurants, if the restaurant did not require proof of vaccination for all staff and patrons, everybody is required to mask while indoors, with the exception that patrons do not need to mask while eating or drinking and being seated. And then finally, the city also required masking in outdoor events with greater than 1,000 attendees. The city also passed rules for city employees. Starting August 11th, all employees were required to mask while indoors, regardless of your vaccination status. And starting September 1, all new hires at the city needed to be vaccinated, and all existing employees that were not vaccinated were required, to double mask while indoors. And there's decent data to say that if you double mask properly, the protection is similar to an N95 respirator, which is what healthcare personnel wear when interacting with folks with COVID. And so really it should be pretty much foolproof if worn properly and fitted properly at preventing an individual from either spreading or contracting COVID. There was a vaccine mandate that was originally scheduled to go into effect on 10/15, and the compliance dates have been delayed somewhat. All healthcare workers must be vaccinated or tested weekly starting the 15th if you weren't fully vaccinated. But the compliance delay right now is that you need to at least have your first vaccination on 10/15 and the second one 28 days later. All staff, faculty, student at colleges and universities in the city must be vaccinated. And if you're not, tested periodically. And again, similar delay for those folks. And then there was a bit of a longer delay for home care workers or behavioral health workers, where they didn't need to get their first vaccination until the 22nd of October. Any individual that has a religious or medical exemption or disability that would make it unsafe to wear a mask must be permitted a reasonable accommodation in any of these rules. There were some questions that were provided to me before the talk that I wanted to go over briefly. And so firstly, masking. So what's the current policy if you have a disability and your disability precludes you from safely wearing a mask? You would not be required to wear a mask when indoors, but you got to realize that you're putting yourself at greater risk of getting COVID. Some options for you might be to wear a face shield, which is not as effective as masking, but again, it's better than nothing. The other thing is to request an accommodation from wherever you're trying to enter, whether it be a private establishment or a city establishment, should you be unable to wear a mask due to your disability. And those entities would be required to provide reasonable accommodation. And as you guys know, though, if there is no reasonable accommodation, then you're going to have to try to figure out what to do from there. What about these different policies and enforcement? The city does not expect, if you went into a private establishment, that they would be getting your medical records and substantiating the validity of your disability. My advice is, if you were in a private or public area and it was unsafe for you to wear a mask, you should explain that to the individual. You don't need to give them your personal medical information, but let them know that you have a disability. Is there an option to accommodate you? If there is not, or you're not happy with how you are treated, I would advise you to leave. I would not get in a fight with somebody, and I would file a complaint with the city office of ADA compliance. Another option would be to get like a generic letter from your healthcare provider that just says that you have a disability that precludes you from safely wearing a mask. It doesn't need to give the reason, and to carry that with you. And if somebody challenged you, you could show them the letter. That might convince them. You might want to bring, again, a face shield. That might convince them. But with all of the tension out there right now, I would be very reluctant to really start a big argument with somebody. I would file a complaint with the city. And again, what does somebody need to show if their disability prevents proper masking? There is no formal rule that the city has. Verbally is the first way that I would go at it. And again, if you chose, you could get a generic note that doesn't divulge any protected health information that you could show the person challenging you. With regard to testing, what sites are physically accessible? In theory, all sites should be. I cannot guarantee that at this time. And one of the reasons for this is that the testing that's going on in the city, it's being done by many different institutions. And so it's not all run by the city. Now, again, based on disability laws, these places should be accessible to people who have disability. My advice would be, if you're going to a testing location, if you can, give them a call before you show up to make sure that they do have accommodations for your particular disability, so you don't get there and get turned away. If you did get there and there were barriers, you should ask them for an accommodation. For example, the city has a mobile testing truck where most people are requested to walk up about 5 or 6 steps and have a seat while they're tested. But if you tell the folks from the city that you have a disability, they will come down to the ground and not make you walk up those steps. So again, in a polite way, ask for an accommodation if one is not available, but better yet, give a call before you show up. The testing department at the COVID containment division is currently querying these sites to make sure that they are accessible. So we may have some better information as we move forward. Again, if you encounter an access to testing, you want to request accommodations. If you do not get a response that's acceptable, you should file a complaint with the City of Philadelphia Office of ADA Compliance. Finally, is there a low-cost take-home option for testing? And there are many, many different tests that are available out there right now. There are some what's referred to as over-the-counter tests, which are collected and administered by a non-medical individual, the person that wants to see if they have COVID. The City COVID Containment Division has some of these tests, and they're currently working out ways of distributing these tests at outreach events, but we're still trying to iron out the logistics of how we support people in taking the test and how we deal with the results. So as of today, the city does not have a low-cost testing option or a free option that we could give you. And if you're really looking for that, you're going to need to check your local pharmacies. There's lots of different tests that are out there nowadays, and the costs are varying. I hate to say it, I expect the costs probably to go up if the Biden administration vaccine mandate goes through, which I'll talk about in a moment also. So federal requirements. Back in September, President Biden had issued a series of some requirements, some recommendations that he wanted our country to follow with the mindset of slowing the spread of COVID. Some of those recommendations and requirements were, firstly, that employers with over 100 workers require vaccination, or if not, engage in weekly testing. And we're going to come back to that shortly. He also required that all healthcare workers at institutions that accepted Medicare or Medicaid dollars require that all healthcare personnel be vaccinated. He required that all federal contractors be vaccinated. He required in some of these rules that employers provide paid time off for workers to get vaccinated. And then he requested that large entertainment venues require proof of vaccination or testing prior to entry. A couple of days ago, on November 5th, the federal government Department of Labor, which is part of OSHA, or OSHA is under the Department of Labor, issued an emergency temporary standard for vaccinations or testing for employers greater than 100 employees. And basically what the emergency temporary standard required was that if employers did not mandate vaccinations, that workers had to be tested weekly for COVID. That emergency temporary standard was estimated to impact over 100 million workers, and it actually was, the legal term is there was a stay. Basically, it's been put on hold since 11/6 due to a Court of Appeals challenge in the Fifth Circuit Court in New Orleans. Unclear where we're going from here. This emergency temporary standard will probably make its way to the Supreme Court, and then we'll know whether President Biden will be able to mandate this to employers with over 100 workers or not. It's probably going to be a little while before we find we're aware of the final answer. Vaccines. As I said earlier, there's 3 vaccines available in the US. There's two mRNA vaccines, the Moderna and Pfizer. Those are two-shot series, or primary series is what we call them. And then there is the J&J viral vector vaccine, which is a one-shot series. For those vaccines that are multi-dose, it is recommended highly that you get the same vaccine for all of your primary series doses, but your booster doses can be from any of the vaccines. We call them mix and match, or heterologous immunizations is a fancy medical term for that. There's no maximum interval between doses, but you want to be close to the recommended interval. If you got a vaccine too early, it doesn't count. You get it too late, it counts, but you don't want to wait too long. The Moderna vaccine, dose 1 and 2 is 28 days apart. Pfizer, 21 days apart. And again, J&J is a one-dose vaccine. For those individuals that have had the mRNA two-dose vaccines, we recommend a third dose 28 days after the second dose for those that are immunocompromised. And by the way, there's tables on the Philadelphia Department of Public Health website to help you figure this out. And you can always call us at the Department of Health and we'll help to figure out what the timing of your vaccine should be. You can get other vaccines at the same time of getting a COVID vaccine. And that's going to be an issue right now with influenza vaccines. So you can get both your COVID vaccine and a flu shot at the same time. If you are a contact and in a quarantine, or you are infected with COVID, we call you a case, and you're in an isolation period, you want to wait till the end of your quarantine or isolation period, respectively, before you go out and get your vaccine. And the main reason for that is you don't want to spread COVID to others. What about those that have had previous infection? So we've been recommending for a while that even if you had COVID in the past, you should still get vaccinated. People have been challenging this because the bottom line is that natural infection does create some level of immunity, and that's the truth. The problem with natural infection, though, is what we're finding is that individuals that get infected naturally will have a range of immune response to the natural infection. And we think your immune response is probably directly related to how severe your case of COVID is, meaning that people with asymptomatic disease or mild disease probably do not develop as much immunity as somebody that has a real severe case of COVID naturally. And to date, we do not have a way to measure whether you're immune at a given point in time. And we're getting there. And eventually we're going to have an antibody test, I think, that will be able to tell us if you're immune or not. But right now we don't. So given that fact, those that had natural infection, their immune response is going to vary. In addition, the immune response tends to wear off over time. Prior data suggested that if you had natural infection, that your natural immunity would reliably last for about 90 days. And right now, the latest data is suggesting that natural immunity, especially if you had more than mild disease, is likely to last up to 120 days. The CDC hasn't changed any recommendations that related to vaccination after natural infection with regard to this 90 to 120 day immunity yet, but that may occur in the near future. You can get vaccinated as soon as you're done your isolation period if you have COVID. It's safe. And we know that you will have better immunity than not getting vaccinated. And again, the latest data that I talked to you about previously, if you compare somebody who had one case of COVID naturally with somebody that's fully vaccinated and never had natural infection, the individual who had natural COVID is about 5 times the risk of being hospitalized with COVID if they were to get another infection. Do you need to keep following other precautions after vaccination? Unfortunately, yes. And the main reason is we see breakthrough cases. Vaccination is the most effective way to prevent you from getting COVID, prevent you from, if you get it, having severe disease, hospitalization, or death, but you can still get COVID. And we need to keep following these other mitigation measures at this point in time, given the case rates. You know, we're having 60, 70,000 cases in the US right now. That's only what we're measuring. There's still a lot of spread, and a lot of us, our immunity is wearing off, whether you had a natural infection or were vaccinated early on in the pandemic. Best things: masking, social distancing, hand washing, avoiding crowded indoor places with poor ventilation or where there's a lot of people. If you get vaccinated, you got to wait 2 weeks to reach peak immunity. And again, right now, if you got an mRNA vaccine for certain groups, we recommend boosters 6 months after your primary series is done. For J&J, 2 months after the first one-shot primary series. And actually, Pfizer yesterday put a request into the FDA to offer boosters to everybody, not just those high-risk groups that I listed earlier. And again, if you do get vaccinated, you're probably at less risk of spreading COVID to others should you get a breakthrough infection. You know, it's a tough decision to get vaccinated. I've been living, eating, breathing this now for over a year. I am convinced, based on science, that getting vaccinated is the lesser risk for individuals. I'm vaccinated, my family's vaccinated. But again, getting vaccinated is not with zero risk. There are some side effects you can get from the vaccines, but those risks are far lower should you get infected with COVID. You know, natural immunity plays into this. We don't know the full story yet, but it really looks like you still want to get vaccinated, even if you've had a case of COVID. I encourage you to talk to respected people, talk to your healthcare providers, read the literature and look for sources. If you read literature and it doesn't include the source, it's probably lousy literature. You know, you want to get stuff that's published by the CDC, New England Journal of Medicine, JAMA, which is the journal at the American Medical Association, Lancet, British Medical Journal. You know, you want to go to respected peer-reviewed areas to get your information. If you see something on the internet that piques your interest, search it. Don't just trust one source. Look at multiple sources. The information continues to evolve. We've learned a lot. We don't know it all. And we will probably forever continue to learn as we do with other medical conditions. You want to consider your own medical history and your age, whether or not you get immunized. If you got chronic medical problems and you're older, you got a much greater risk than if you're a younger, healthier individual. And then bottom line, make an informed decision that's best for you. I certainly hope that that is getting vaccinated. There's few people that cannot. The only people right now that we say don't get vaccinated is if you have a severe allergy to a component of the vaccine, or you've had a severe allergy to a prior dose of a COVID vaccine. And even if that's the case, we got 3 different vaccines to choose from for subsequent doses. These are some resources, websites for more information, and I'd like to open it up for some discussions now. And I will try to unshare my screen if I can do that. Okay, there we go. Can I entertain any questions?
I want to hop on here, and I apologize for my microphone. It looks like I may have been, I've had issues earlier, so I apologize. But if you could raise your hand or type your question in the chat. I realize we're running low on time.
And Lee, I'm happy to stay as long as there are questions. So I'm free. Again, I'm free with time. Don't make me the limiting factor here.
Okay, thank you. Yeah, it looks like Erman and Jalen have a question.
This is Herman, and I'll go straight to it for time's sake. Thank you, Dr. Bennett. So many questions, but 2 big ones around what will the city, or what will be the city's approach to vaccinating, and considering that there is this now it's in litigation. What is the city going to approach nonetheless for employers over 100 people? And secondly, and Actually, this could have some context. I don't even need to take this back. Considering your statement around the lack of um, purchasable testing, right? Considering the lack of testing for children in schools, children, all this going on now, the potential need to testing and not being accessible to our communities, Spanish, not English speaking communities, our multiply marginalized communities. This is a big problem, considering the President Biden said that there's so much purchase of for this. What is going on?
So, I want to be cautious of making predictions. And part of the reason for that is I've been wrong a lot over the past year. The federal government's vaccine or testing mandate right now is on hold. What I read, some people think it's going to withstand the legal challenges and others do not. My opinion, if it does withstand the legal challenges, there's going to be a huge increase in demand for testing. And I don't know how that's going to play out. And it concerns me because the city has some vaccine mandates. And for those entities that have flexibility, where, healthcare, everybody needs to be tested, with the exception of those that have a religious or disability exemption. But for example, at university, well, actually, I shouldn't say that. Healthcare workers can opt out and get tested. And also, universities, if they don't have a vaccine mandate, can opt out of that, which includes testing. Those city requirements, as I understand, they are in effect. They are not going to change as far as I know. There is no specific legal challenge that I'm aware of. So that stands. And there is some options for testing, which again will increase the demand for testing should those employers not mandate vaccination. So, I guess I don't really have a great answer here, but I do agree that there's very likely to be a rush for all these tests. And what are you going to do if you can't get a test in the time frame that's required? Will the authorities ease up on that, or will you need to stay out of the workplace? Don't know. I don't think we're there yet, but I do think if this federal requirement is ultimately determined to be legal, I think we're going to have some challenges, and it may be different in different areas of the country too. So sorry that I didn't have a better answer for you.
Can I just ask a follow-up question that might be helpful? Where could residents or community partners direct that question around testing? Who would be the appropriate entity? Would that be the COVID containment group? Would that be the Department of Health? Could you clarify where questions and concerns around testing and vaccination mandates can be directed?
So if it's a broader question, I would say to pose the question with the Department of Public Health. If it's a question about your specific employer, like say you work in a healthcare institution or an institute of higher learning, a college or university, I would go to your human resources department within there to get specific questions about your situation. But again, if you have broader questions, I would pose them to the Department of Public Health. Is there any other questions?
Well, this is Ramon. Would you entertain how are booster shots going to, since you recommend and it's recommended that they are within the cycle recommended, all the people that I myself got a booster shot at the Moderna shots in my home with the help of the Black Doctors Consortium. And I know Anna Perg has gone on a different approach for those that received it at home, those that received it in congregate care settings, including prisons, not only care settings, that is matching the suggested and recommended cycle. We don't see the surplus of federal support. how are people going to meet the guidance without the equal governmental support that existed during the first phases?
So that's a good question. And one of the observations that I've made, and I don't think I stated this previously, is with all these different rules where we're defining full vaccination, none of the current rules account for boosters. And what I mean by that is you're considered fully vaccinated for all these different rules if you've had either 2 of the mRNA vaccines or 1 of the J&J vaccine. So from a perspective of being restricted from public locations or your job, the boosters right now doesn't matter, boosted or not, whether you fall in a group that was recommended, offered, or not offered. Booster doses are, my understanding, as long as you're getting it per the CDC recommendation, the booster dose is paid for by the federal government. The federal government, though, like when you go to a vaccine site, they may ask you for your insurance card because whoever is administering the vaccine is permitted to bill the insurer for the administration of the vaccine, not for the vaccine itself, but for the administration. And you as the recipient should not be charged anything. But again, like sometimes I got a booster and they asked me for my insurance card. Sometimes people were a bit reluctant to give the insurance, but what's happening there is that entity that's administering the vaccine is going to bill the insurer for the administration. You should not see any bills. Beyond that, in terms of recommendations, I mean, I can tell you that the city of Philadelphia is establishing, we call them resource hubs, where you will be able to get either tested or vaccinated. And we do have a mobile testing and vaccination program. And if you are homebound, I would encourage you to pose a question with the Department of Public Health to see what resources the city has to help get you vaccinated. So that's pretty much all I have. Thank you.
I'm sorry. I just want to be aware of the time here, and so I'm going to post my email in the chat. So please, if you have any other questions, please email me. Of course, you're welcome to stay and chat for as long as we have the doctor. But thank you all so much for attending today. Thank you, and so please email or raise your hand.
And once again, I appreciate being invited to speak to you guys. And again, I'm fine to hang on as long as there's questions. Again, our goal at PDPH is to provide good information and allow you guys to make good decisions in how you're living your lives and whether you get vaccinated. So again, I'm fine to stay on.
Well, I also wanted to, sorry, Liam. I wanted to also echo Liam's thanks and gratitude to you, Dr. Mannon, and for everyone attending today. I do see a question from Lauren.
Thank you. Thank you, Dr. Mannon. I really appreciate that presentation. There was a lot of great information in there. And I guess my question is really about my concern about the variant in the UK. So I just got my booster, and my daughter is about to get her vaccine. She's 5 years old this weekend. And, I think just with the court decision today to take away the mask mandate in schools, my question is kind of broad, but how concerned should we be about this variant that's in the UK that seems really aggressive, even if we have our vaccines and boosters?
Yeah. Not to belittle this pandemic. It's been horrible for many of us. With that said, there's some interesting science here. And in terms of variants, we are likely to continue to see variants. And the main reason there is again, variants get produced when the virus infects an individual. And so while we might be able to get good vaccination rates in the US, we really need to do it throughout the world in order to slow down the development of these variants. The development of the variants, it's a random process, we believe. It's when the genetic information of the virus gets encoded in a new virus. When it reproduces, you can have errors there. And so the more viral reproduction you get, the more random chance you have of getting a variant. Most of these variants are nothing. The genetic changes do not lead to any problems, but occasionally there are. And again, more cases, more likely it's to occur. Based on some theories of evolution, what we expect in the long run, and when I say the long run, that's not months and probably not even years, but in the long run, what you expect is that the strain of the virus that is easiest to spread will eventually become the main virus in the society. And interestingly, it's usually not the most deadly virus, because if the virus killed every single person that it was in, it wouldn't have people to spread. So what you tend to see in the long run is those viruses that are easier to spread becoming the predominant virus. And that's what's happened with the Delta. The data is too early right now, from what I'm reading, to really say with confidence what's going to happen with this Delta Plus. In the UK, I believe it's currently about 10% of the cases. Now, some of that is just plain old statistical, based on the statistics, because the UK has been the country in the entire world that has been performing the most sequencing, which is the name for the test to determine what the strain of virus is in an individual. So they've been doing way more sequencing than we have in the US. So they're going to find these subvariants or variants earlier than others just because of measurement. And so again, right now, not too sure if that Delta Plus is going to prove to be a big problem. If it is more transmissible, yes, eventually it'll overtake the prior Delta variant. Just really too soon to say. I think it's a good idea to get a booster if you're due for it, especially before the holidays. We're going to start getting indoors. All of us are just fed up with this and maybe taking more risk than we did a year ago. And if you're going to get together with friends and family indoors, to me, make sure you're immunized. And, you might want to look at some other mitigation measures if there are individuals in those gatherings that are at high risk should they get COVID. So bottom line, really don't know just yet how significant that Delta Plus is going to be. Thank you.
Thank you so much for that information. I have a follow-up question. I have a daughter who has medical complexities and is vaccinated, but she's under the age of 18. So when we were learning just as a family about the boosters, I had reached out to Children's Hospital and they had informed me that at this time, boosters are not recommended for those under the age of 18. So do you foresee or have any guidance or input on for those that are medically complex that we definitely would want, I really would love for her to have a booster, but she's unfortunately ineligible to get a booster. How are we ensuring that children remain vaccinated?
If you could bear with me for just a second, I just got to check one of my notes so I don't give you wrong information.
Sure.
Again,
and if it needs to wait till as a follow-up, that's
I have
fine
this
too.
in another PowerPoint that I was just looking at today, and I don't want to give you wrong information. Yeah. So boosters are not recommended. You are correct for those under the age of 18 at this time. How old is your child?
She's 17, but she won't be 18 until August.
Okay. Again, the vaccines are not yet approved for her. When she hits 18, if she's 6 months from receiving her last dose, she could get a booster. Now, if she is moderately or severely immunocompromised and she received a mRNA vaccine, which is Pfizer or Moderna, she would be entitled to a third dose.
That's where we're having difficulty finding a provider because she is, but because of her age, she's in this space where we haven't been able to find a provider that will provide her that booster.
That might be a good question to pose at the Department of Public Health.
Okay.
Because if I'm understanding this correctly, and I hope I'm not giving bad information here, because again, this vaccine stuff, it has gotten so confusing, I gotta say.
And that's why we appreciate you presenting to our group and to our forum to help clarify some of that. So we really appreciate your time.
Yeah, and the notes that I'm looking at, again, if she's 17, she should be entitled to a third dose, which is not a booster. And that might also be something when you call a location. If you use the word booster, they're going to say no. If you say my daughter has a moderate or severely immunocompromised state and needs a third dose, I think that might have been the difference. But if you're having trouble, I encourage you to reach out to the public health department, because we're administering vaccines and we can give you a place to go where we would administer the vaccine to her.
Okay, wonderful. I really appreciate that. And I think those are the kinds of things that we don't always know or understand about the language we use, even working in the city. And so I think I definitely appreciate this and that information. And just looking at the time and knowing to be respectful of the interpreter's time as well, give one last call for questions, and then we're gonna close today's forum, but we'll be sure to follow up. If there's additional questions, Liam can yield them, and we'll certainly connect folks to the Department of Health, and the mayor's office is happy to assist folks as well.
This is Debbie Russell. I had a question about following up to get the booster. What's the best way to do that? I know that there was a lot of difficulty initially connecting to get the vaccine itself. I know people had difficulty getting online to be able to register because that's what they were pushing for people to do.
My understanding is at this time, there is ample supply of vaccine in the city. And if you go in, I mean, ideally, they're going to want to see your card to make sure that you're not getting it too soon. Again, if you got the mRNA vaccines, it's 6 months from the last shot. And if you were somebody that had a third shot because you were immunocompromised, again, the booster would be 6 months from that last shot. And there are certain groups that it's recommended in, but it's basically on the honor system right now. If you go in and tell them that you're in one of these groups, you will get a booster. And then again, J&J is everybody who got it 2 months after the first shot. And part of the reasoning there might be that shot will eventually become a 2-dose vaccine. And so again, you should be able to access vaccine. If you're having trouble, again, I would reach out to the Department of Public Health and we can assist you. And there should be some sites on the PDPH website that you can also find locations. But again, if you're having trouble, reach out to Public Health. Right now, you should not have trouble finding a vaccine.
Thank you.
Thank you.
Thank you for that. And just for everyone, I've dropped in the chat several links, but Debbie, to follow up with you, the phone number is there as well for folks that can't do the online portal for vaccinations, as well as the link.
Thank you.
And I just included the link for the homebound vaccination program for those that are not able to get to a vaccination location because they are homebound resident. Liam, did you have any closing remarks?
I just wanted to thank everyone for attending today, and you are listening to this after the fact, we'll be sure to include all of the links mentioned in our streaming of this video. Thank you, Dr. Madden, and thank you, Amy, for your help and monitoring the chat, and thank you all for attending.
Thank you for
Well, close
hosting
it up there.
and all the work that you're doing. Thank you again to Dr.
Yes.
Mannon and all of our participants and our interpreters as well.
Thank you for hosting. Thank you. You have
Yes.
a wonderful day.
Yes, thank you very much. Everybody take care. Stay
You too.
safe.
All right. Bye-bye, everyone.